Recording. Good morning, Liam. Good morning, Seong. Good morning, Connie. Welcome. All right, let's begin. Seong, do you have any updates? I saw your posters.
Yes. I heard from Dr. Liam that all three posters were confirmed, so um they were sent for print last week.
Okay.
And today, while I was talking with Dr. Liam, he asked me to show this to you and maybe ask if you might want to send this out for word long, which is due this Friday. If
Okay.
you can recall, this is the durable response abstract. And this abstract was actually finished by Dr. Jian Lee, when
Mhm.
she was here, and she was trying to confirm it with you for AACR. And Monica was trying to send this out as a first author. But at the last review and feedback, I was informed from Dr. Liam that you wanted to go for more um analysis and rebuild it and send it for others. So I was trying to check what further analysis you're looking for and see if this can be fit for word long, or if not, then SITC.
So what is updated?
The update is, while I was looking at this, I also recognized that the durable response part, this is something that I also have done further analysis when I was there. So if I were to show you
Okay.
this one. The abstract that was written by Dr. Lee, it says here she used 127 consecutive patients, and she only used intrathoracic lesions with only IR resist analysis. And with this, from what I know, 205, I believe. Yes, 200, oh, 200 and, yes, 205 patients. Using the durable response definition of CRPR and SD of 24 weeks, I remember going through few detailed patients with you and checking with Dr. Jian and Taegyu and completing the durable responders by resist, iResist, and iResist. So right now we do have durable responder data with all 205 patients.
Okay.
And so, and we also have the intrathoracic only patients marked. So if we were to do further analysis, I think this is possible.
Mm. Okay. So show me the original abstract.
Yes.
Let's
So,
look at the title one more time.
yes.
So the title is Survival Outcome Clinical Factors Associated with Durable Response in Intrathoracic Lesions.
Mhm.
In intrathoracic lesions.
So it says here on the last comment that I think you gave comments to do intravenous extra or intravenous total. But at the time when Dr. Cheong was leaving, I guess she only had durable responders only for intrathoracic. So
Mm,
it wasn't possible to do further analysis.
mm,
And this was the title.
mm.
Can I
So
go down?
yeah,
Mhm.
so now you're saying we have the total resist?
Yes, that's what I believe. Wait, let me check. Oh, actually, no, I was confused with the intrathoracic only patients, but um
So this has not been submitted yet, this abstract.
no.
Okay. Liam, what was the
Um,
reason this wasn't submitted?
I don't remember. I,
But it has never been submitted.
it has not been submitted.
Okay. Show me the text the abstract.
yes, just to make sure. I just want to make this clear before going on. So we do have the patients marked whether they have only interthoracic or they also have lesions outside thoracic. But for instance, this patient L001 also includes extrathoracic lesions. But when we go to RECIST and the response criteria, we only use lesions that are inside the thorax. So we can't say we have the total RECIST response, I would say. So these,
Why is well, I guess it's less than 15 millimeters. Is that why?
mm, I don't think so. I think the lesion itself also include the extrathoracics. They also include lesions that are more than 15. I'm not sure about this. I think I have to check on the epics again. But I think it was related to the radiomics. This whole data is based on radiomics. So when we do radiomic segmentations, we only look at the lesions that are inside the lung. So referring to that, I think the prior team collected data that are related to the CT scans. I'm not quite sure because when I was signed out from Dr. Chion and Taegyu, they told me to get rid of all the lesions that are outside the thoracic and get target lesions that are only from here. But I to just make sure, I think it should be
So
looked
if
through
you
Epic.
look at SLD, it's sum of the largest diameter. So it's sum.
Mm-hmm.
I don't think it's the lesion, it's the sum of the lesions. Okay.
Mm-hmm.
So you have all the measurement. So
All
this,
right, you're right. I'm sorry. I'm getting confused. They have right buttocks and pancreas.
so it's all measured and looks like, there's a regular resist done, and then
Mm-hmm.
you can do a intrathoracic resist. I think it's somewhere. So I think you
Uh,
have all the information.
I think so, but I don't recall doing only intrathoracic, but I can check. Oh, yeah, I think we did it separately, but I don't think it's here. Sorry, I'm quite lost, but it says systematic, so I can check if there's also interthoracic version of this. So if that's the case, I think we have the both total and interthoracic.
So go back to the abstract. I think this is definitely something we can present at the World Lung. The question is, if we just look at the CT chest, how concordant is it to the overall response in lung cancer, non-small cell? So
Mhm.
here it says 266 intrathoracic lesion from 127 patients, and durable responses. So here, go down. 1 CR, PR, SD, PD, median duration of immunotherapy. In contrast to general IR resist assessment, tumor mutational burden or PDL1 status were not associated with the durable response when IR resist was evaluated only with intrathoracic lesions. However, similar to the general IR resist assessment, durable response rate was significantly higher in patients with a normal baseline platelet count or who received combination immunotherapy and chemotherapy. So it's not so interesting because so I think before you embark on any project, you have to ask yourself, you know, what's the question we're asking? Is that question important, meaning high unmet need clinically? And by answering that question, what's going to change in in clinical practice? If you have no clue, if you don't have good answer to those two questions, then you're wasting your time. So the question here is, there's so many papers looking at clinical predictors of response in patient getting immunotherapy. So many papers. Now, we don't want to be Me Too paper. Now, I've never seen a paper just looking at intrathoracic response. I don't know. You can look for it and write that in your introduction and discussion when you write the paper. Now, the question is tumor heterogeneity. You can give same treatment and you can have a beautiful response seen in intrathoracic lesion, but your adrenal gland might just explode. So it's a matter of heterogeneity. So you can put it in a very different way. And then that's kind of the mixed response project that we have currently. Who's doing the mixed response in non-small cell lung cancer, Liam? Who's the lead author?
I think.
So it would be Monica. It's from the radiomics data set, right?
But it doesn't have to be radiomics.
Yeah, as of right now, it started with Dr.Chae, and then it's been, as of now, it's been handed off to Monica and Peter.
Okay. Okay, anyway, so it's in line with mixed response concept. Now, the question we're asking here is, it's intrathoracic response concordant with overall response? The answer is no. It's going to be different. Then the contribution is knowing how different and will the predictors be any different? Meaning, you know, the traditional predictors of response to overall response versus intrathoracic response. Are there going to be any differences? So why don't you write a new abstract focusing on what I just said, Theo? And this is all
I see.
recorded, so you can go back to my comments if you have any questions. But I do think the way it is not interesting at all. And then the difference between IR resist, I resist, or regular resist is really not the focus. You can report it in any way you want, as long as you find something significant using different definitions. We're not interested in making a point that each different definitions will yield different results. No, we all know that for sure. So the question we want to ask, go back to the title. Can you go back to the title? Yeah. So survival outcomes and clinical factors associated with durable response in intrathoracic lesions of non-small cell lung cancer treated with immunotherapy. So intrathoracic durable responses in intrathoracic lesion versus overall disease, let's say overall lesion. It's like overall lesions. It's too many words. So in intrathoracic versus overall lesions of non-small cell lung cancer treating. Yeah, so focus on the difference.
But when you talk about difference, oh, you can go on.
Yeah, no, go ahead.
So when we compare the difference, in what ways are you expecting to show this? Like, would it be enough to show them how many the durable responses were there, or just comparing simple statistics would be enough? Or
Yeah, percentage of response rates, durable response rate is enough. And survival outcome may mean progression-free survival, overall survival. So Kaplan-Meier curve, log rank, p-value differences, hazard ratio differences between responses seen if you have durable response in thoracic lesion versus overall lesion. How
I see. Then regarding the comment that you said, will the predictors be any different? Can you elaborate on what kind of predictors you're referring to?
yeah, so this abstract has PDL1 and TMB platelet count. So anything that was used here, you can use it too.
Oh, then I'm just not familiar with all the statistical analysis. I'm not quite sure what statistical analysis Dr. Chian used to get these. Are these t-tests, or what am I supposed to?
So just like you use PDL1 high versus low, you can do it 50% higher versus other. You can do positive by 1% or less than 1%. Just do every test by yes or no. So you can do platelet 400,000 lower or higher, yes or no. You can do combo versus mono, yes or no. So you don't have to use a continuous variable. You can use binomial.
Okay. And using these binomial, am I looking for t-tests or?
If you're doing response rates, then you are looking at yes or no, and then you're looking at the rate difference. So that would be the percentage difference. So you could do 2x2 table statistics. If you're doing a survival curve, you can do Kaplan-Meier log rank or logistic regression with the hazard ratio p-value.
Oh, so what? So would it be chi-square I'm just
You can do
not
chi-square or the Fisher's exact p-value for 2x2 tables.
okay. It's just that I've never done Fishers or chi-square without much supervision. So is there anyone or like a guide that I can look up to?
Maybe Liam and Sally's done MPH, so that's
Mm.
sort of basic clinical statistics, so they might be able to help you.
Okay. Then I see.
So do what you can to
Mhm.
show the difference between intrathoracic versus overall. I think doing extra thoracic is gonna take too much time right now.
Yeah.
But I think intrathoracic and overall is already done. You just have to find the right value.
Right. I think I'll have to just check and make sure there is a total and intrathoracic and
But we just looked at it. It has total for sure. Intrathoracic, you already have.
yeah.
You just have to look at the intrathoracic lesions, and it's already calculated for you. So to me, it's already there.
Right, but I remember like the Excel functions when I got here. I don't know. I'm not quite sure how Dr. Chae used it, but the Excel functions were not all implied. So I remember implying them and erasing the extra thoracic lesion didn't just magically work up right away. So I remember like fixing the values like the ranges manually by each cells. So I
Mhm.
just want to make sure that it was completely done in there. And after checking that, I'll update as much as I can. I just also want to tell you that I'm catching a flight in a couple of hours and wouldn't be able to do the SPSS online. So I'll try my best to do it before Friday CST, which I believe is the deadline. But yeah,
Okay,
and
sounds
that'll
good.
be it.
Yeah, just work with Liam so that he will catch me to get any feedback real time. Okay.
Mhm. Thank you.
All right. Anything else, Hale?
No, that's it for me. Thank you.
Okay, so I'll see you in San Diego. Or did you
Yes.
okay. When are you arriving?
I'm arriving on Saturday. I Yeah, regarding the flights and things, the flight to LA was cheaper, so I booked that one. So from LA, I'll travel down to San Diego on Saturday.
Okay, good. I'll see you then.
Thank you.
Thank you. Okay, let's go to Seoin.
Can you hear me?
Hmm?
Okay, I'll share my screen. So I have this abstract for Tempest ready. So I want to just have you confirm the author list and the results section.
Okay. The author is Seoin, Haesung, Wongi, Liam, Eugene, Calvin, and Vanessa. How did Eugene got involved in this?
So
Um,
this project started, oh, sorry, yeah, just to touch on here. Dr. Eugene's the one who started the proposal for Tempest 2 years ago. And so she kind of started the project and then it got handed off to Haesung. So I thought we would kind of need to acknowledge her.
I see. Okay, so let her have chance to look at the abstract before it's submitted. All the authors, make sure it's sent to everybody. Okay.
okay.
Okay, go down.
Mhm.
So investigating the clinical outcomes and molecular landscape of invasive mucinous adenocarcinoma of the lung. I think we can take out the investigating. Wait, it's so I would okay. Yeah, method looks okay. Okay, 3.5 IMA, 96 non-IMA. So we're saying TMB 4.2 versus the 3.1 versus 4, 7 versus 9. Okay, pretty straightforward. So did Chae do most of the analysis?
The analysis was actually done by Tempest, but I kind of changed the focus of this abstract to gene analysis and tumor microenvironment because I think Dr. Wangi and I are going to do further analysis gene by gene and do the Cox regression test to see what's actually the risk factor for poor prognosis. So that was the different focus compared to the ASCO Tempest abstract. So I think all the M2 macrophages, I was gonna give you give all the lab members a brief introduction of the macro type difference and some of the gene functions.
Yeah.
But M2 so do you want me to go ahead and
Yes, no, show me table 1.
table 1? Okay.
Okay. So more B cells. Is it less M1? More
Less M1 and more M2.
yeah, and less neutrophil, less CD8T, more NK, more Treg.
More Treg.
And table figure,
Figure 1.
yeah. So they do worse with yeah. Yeah, I think with that large data, this is a pretty good data. And I wonder if we and Tempest people who send NGS are usually stage 4. So this is stage 4 IMA. So it's very different from SEER data. But I wonder if you just do SEER stage 4, I wonder if the SEER mucinous, non-mucinous stage 4 only would look like this. Just double check that with you, John. Okay. But anyway, this is good of itself. Good job. And I think this will definitely get into the world long. Because I haven't seen IMA with this large data and this much in-depth study. So yeah.
So I just wanted to just briefly explain what this might imply. So there are two I think subjects, tumor microenvironment and gene expression analysis. And as you saw, has more M2 macrophages and Treg cells and fewer PD-L1s, status, and lesser TMB. So if you look at the macrophage type, M1 is the one that we actually know more. It's acute inflammatory and anti-tumor effect, whereas M2 is more like pro-repair and pro-tumor. So it suppresses immune system. So that's why IMA has more M2 macrophages and Treg cells.
Okay.
So another role of M2 macrophage is to promote tissue remodeling and repair tumor progression and metastasis. So maybe that's why IMA shows this multifocal distribution. Maybe this could be
How do you know it's multifocal?
It's actually known like it acts like pneumonia and metastasis, multilobar and multifocal distribution. So there are many papers that says the IMA shows a high propensity for multifocal distribution.
Oh no, you're talking multifocal tumor distribution, not.
Yeah.
I thought you were talking about M2 distribution.
No, I was saying M2 macrophage, maybe it that's why IMA shows multifocal distribution.
Okay, understood.
Could be the mechanism behind its clinical characteristics. And also fewer PD-L1 and TMB. I talked with you, Dr. Chae, about hot and cold tumor yesterday, and probably this implies its IMA tends to be cold tumor. And this is a good picture of what cold tumor and hot tumors are. So in cold tumor, you have more Treg cells and I guess M2 macrophage, whereas hot tumor, you have M1 T effector, which is CD8 that directly kills cancer cells. So, IMA, as we did a analysis based on the treatment, it didn't show a lot of improvement in overall survival with immunotherapy, and maybe that's why, because it's cold tumor, it's resistant to immunotherapy, and it has poor prognosis. And it's the first picture that we are thinking about IMA. And next gene expression analysis, it showed a lot of different genetic profile compared to non-IMA. And like those 3 genes are actually involved in gastrointestinal homeostasis. And it is actually known, there is a paper that says IMA acts like GI cancer. So that explains why, genetic wise. And this IL-36RN is actually involved in immune surveillance. So we could actually do further analysis on using this individual genes that could play an important role in making IMA distinguishable from non-IMAs. So we wanted to ask you if you recognize any genes that are already known in clinical settings. That's what Dr. Wangi wanted to check with you.
Yeah. So only thing I would say is CA-CAM.
CA-CAM.
Yeah, CAM is important gene in also GI cancer. And it's a known tumor antigen.
Right.
So look into that. I don't know how this gene plays a role in IMA, but and then I would say the other one is obviously it has a lot of mucin, so mucin 17. There's a whole variety of MUC genes, but
right.
Not sure why 17 popped up here versus other MUC genes, but and then and then eightfold I would look into. I don't know those the other ones link but read what I read more about what those are. But I think the red genes, like you said, are important GI mucosal integrity. So I yeah, I would read more about it and see anyone has ever studied these genes in the context of immunotherapy response.
Mhm.
Because there's a reason why colorectal cancer, pancreatic cancer, gallbladder cancer, gastric cancer, unless they are MSI high, they don't respond to immunotherapy alone. So we think the mucin or the GI epithelial features do play a big role, and no one has ever been able to sort of hone down the deep biology behind it. But you can start with studying these genes, and what you can do it with the CBio portal, TCGA, they all have the RNA sequencing data. So you can look at the GI tumors versus lung cancers, and when these genes are highly expressed, their survival might be vastly different. So you can do those preliminary analysis to validate your hypothesis. So yeah, there's so many things you can do. And then there are immunotherapy cohorts where these genes have been analyzed. So you could so the other thing is this is IMA versus non-IMA, but IMA defined by our IC, like the diagnostic code, is not perfect, right? So you could we can ask Tempest, we can propose the second project. Well, these are the candidate genes. We want to look at the panel of genes hyperexpressed versus downregulated and see how the survival changes in all the lung cancer patients that were RNA-seq. So we can do that with the Tempest data as well. So keep thinking about what the best next step, but we have to understand the gene and the biology first. But good thought. Okay.
So yeah, maybe so that the next step could be like think of a biomarker to predict the coldness of tumor, since it could be related to resistance to immunotherapy and
Yeah.
progression after treatments. And I've done the DW that was assigned to me before I went to go to Korea. So that's it. Thank you.
Where are you with the Genome Insight project?
Oh, so yeah, actually, like because all the cohort A patients have bilateral lung and mucinous adenocarcinoma, I was thinking if I could do whole genome sequencing and see if the genes that I just mentioned before are highly upregulated in all of the patients, and if that could be another.
So yeah, you don't have to have well, you can write those stories, but it's gonna be a unbiased comprehensive analysis. But the thing is you don't have a control, so everyone is going to undergo whole genome. So it's more about what whole genome can do, right? And we heard important stories of how it's going to be a disruptive technology for understanding the germline landscape. But so many enhancers and so many non-coding variants are important. And I bet they are not only germline, but there are other somatic or founder mutations that would have huge impact on pathobiology of such cancers. And here the whole question is, who are the right candidate for DREAM project? Who are they? And how do you select them? what is the pathobiology behind it. So to do that, we need to do whole genome sequencing as well as a whole RNA sequencing, right? What pathway is turned on? What mutations are there? Not just the mutations, but the clonality of the whole bilateral disease burden. So the idea is let's biopsy all the multifocal lesions and draw a phylogenetic tree based on it. Just like Charlie Swanton's papers, right?
Mhm.
So the idea is let's write a proposal doing on all those analysis, and you can read pivotal papers describing the methodologies and apply that into your proposal paper.
Mhm.
Uh, okay, so
So,
keep writing it, and if you run into questions, just ask me real time.
okay, so you want to come up with the phylogenetic tree of the dream patients. That's the one of the primary
Of each single patient.
each
So
single
the
patient.
idea is you're going to run into two types. One type is indolent multifocal cancers that are multifocal stage 1 cancers. We call this field cancerization, where there's lung and it's all affected by the carcinogen. Sometimes it's air pollution, sometimes it's just simple cigarette smoking. And then all the tumors will pop up. And if you draw a phylogenetic tree, none of them are related. Okay. They're just all different stage 1s. Versus you have STOTs with which is called spread through airway space. Then you have one clone that goes through the trachea, lands somewhere, and this clone travels through the mucin, through the bronchial alveolar pathway, not through lymphatics or bloodstream, land somewhere. So if you draw a phylogenetic tree, they're all related. So my guess is everyone's phylogenetic trees will look very different. And understanding that landscape will give us an idea how the tumor is spreading. And we know that for metastatic cancers, because we biopsy adrenal gland, brain, lung. But here, this is unique because we're talking about just lung limited tumors. What is their genetic genetic clonality? So we want to be able to understand that in order to find the best candidate for dream patients. So this is, no one's ever heard of these projects. This is the world's first undertaking.
I'll look into our papers from Swanton's lab and come up with a proposal.
And look into what whole genome can do versus whole exome. And then having RNA-seq will give us the whole immune landscape too. And then we can look at the immune cells too by staining for immune cells. We can stain M1, M2, can do anything, okay?
Okay.
And I think it's easier to get that grant to stain M1, M2, all of that, because Dr. Barat's lab already has some funding and I have some funding. We can stain that. It's not a problem. So, because RNA-seq, the Tempus is only an indirect way of measuring. So this is a hypothesis driven, meaning, let's say if these genes are expressed, we are guessing that CD8 T cells are there.
Okay.
But it's a guess. It's not directly staining for cells.
Okay.
So it's not going to be correct all the time. So it's better to, so the best way to do this,
Mm-hmm.
spare more samples, is to do multiplex immunofluorescence,
Mm-hmm.
tagging different immune cells.
Right.
So I think you can put that in your proposal. It doesn't have to be Genome Insight lab, but say if we stain it, then what can we do? We can correlate that immune phenotype
Mm-hmm.
to the sequencing of that specific region. Let's say if you have overexpression of this gene in this multifocal area, the immune landscape looks like this. So imagine that as like if it happens within one same patient, that's a
Mm-hmm.
control of itself. The germline is gonna be the same, the other microenvironments are same, but if you have two different clones in two different areas, your immune landscape is gonna be different by what DNA mutations they have, what RNA genes are overexpressed. So you can look at those intertumoral differences, genetic,
Mhm.
transcriptomic, and immune cell landscape wise. So this is a very important project. Welcome aboard. You you could this is endless mine you can dig into. But definitely we're gonna visit I think it's they changed to Inocrest. Yeah, we'll visit their lab together. So
Okay.
okay. Anything
Yeah.
else? Sorry.
No, that was it.
Okay. Good. Let's go to Chongwoo. Oh, wait. Sorry, did you have a journal club?
Actually, I think it was Su 선생님.
I
But
was supposed to do a journal
Okay.
club, but I was first.
I don't, yeah, but do you have time to do it, Sue, or do you rather do it following next time?
If I could do it next week, I would appreciate it.
Yeah. Next week I am still away, so next week let's do it.
That makes sense.
Okay, that's fine. Soin, some of the Swanton paper I told you to read, just
mm-hmm.
read it and just personally summarize it to me and I'll give you the feedback, okay? Because we
Okay.
don't have time, you don't have time.
Okay.
Okay, let's go to Changwoo.
Can you hear me?
Yeah,
Yes, so for the last week, I helped Dr. Isu's project with blood TMB and tissue TMB project. So I helped her collecting data. So this is our data, and Dr. Isu is on her way writing abstract. And secondly, I helped Dr. Yu Jung with SEER research project, and Dr. Yu Jung will present later for comparing IMA and non-IMA cases. And for me, I will present about just IMA cases. So in SEER database, we collected about 3,000 patients, and their characteristics are like this. So, and I analyzed the survival by stage in IMA, and this is overall survival, and this is lung cancer specific survival. So while analyzing the data, we found out that bilateral N0 patients and unilateral N1 to 3 patients have similar overall survival. And also we tried to compare N10 M1A patients with N23 M0 patients, but there was a significant difference between them. So
So hold on. So N0 M1A. Can you go back?
Hmm.
So this is bilateral. So M1A,
oh yeah, it's I think this
what
was
is the difference? M1A involves I think pleural disease too.
yes, pleural invasion or pericardial effusion or pleural effusion.
Yeah, so it's a bad factor and it's someone we would never do transplant, right? So the difference between bilateral versus M1A is that if you add those things that you just mentioned, it's a bad prognosis. But let's just compare that bilateral and zero M1C. How do they compare? Can you
Or what do you mean by M1 staging, comparing by M1A and M1B and M1C?
no, let's assume everyone is N0. And then what's the difference between just bilateral versus M1A?
Um, I think there would be dif- there would be plural invasion cases in M1A group.
Yeah, show me the
And
graph again. Show me the graph. So N0, M1A.
and also this is divided by N01 stage and N23 stage. So
So if you look at the red graph, that's the N0, M1A, right?
mm,
And let's look at 40-year survival, which is 25%, 40 month. So next time you do it, translate that into years, okay?
yeah, I
Better,
see.
it's a better way to. Now go back to the prior graph. Okay, so here the 40 month is about 2.5. So similar, I guess.
Mhm.
But I don't know, I can't. Um, maybe slightly better. I'm not sure. So what I'm saying is the purpose of doing this analysis, yes, is of course we want to understand prognostic uniqueness
Mhm.
of invasive mucinous, but also at the same time, the ideal candidate for dream patients
Mhm.
are invasive mucinous lung cancer patients that are bilateral, but they are N0. Sometimes they can be N1. And people don't know how these cancers behave. So we want to tell the world this is how they behave. As opposed to all the regular lung cancers. So what is so unique about mucinous that other non-mucinous cancers show? So that's the question we're asking. Okay. Okay, keep going.
So for these groups, I draw a table, and for gender and ethnicity and age, they were not significantly different. So I thought we could um we could say that survival rates are not significantly different between two groups.
Mhm. Uh, mm, so this is a I would say clinically difficult conclusion. Let me tell you why. Unilateral N1, 2, 3 are all treated very differently. Surgery, chemo radiation. Bilateral N0s are treated very differently. Sometimes there's no treatment. You watch. Sometimes you do wedge resection here and there. Sometimes you do SBRT. Sometimes you treat with one with surgery, one with radiation. So when treatments are whole heterogeneous, you can never make any conclusion here.
Mhm.
Okay. So I don't think people would be interested in this conclusion. It bears no clinical significance. It's a good statistical exercise. Again, the question we want to ask is what is unique about invasive mucinous? When you have bilateral N0, is there a difference in prognosis in mucinous versus non-mucinous?
Mhm.
Um, in mucinous, my hypothesis is there's two different types. One with just parenchymal disease, which is going to be by unilateral or bilateral parenchymal disease without any lymph node or distant metastasis involvement. And the ones that are prone to metastasize to any lymph nodes or distant organs. I believe there are two types. And showing a prognostic difference in those two types within mucinous is sort of my area of interest. Again, by staging, how is mucinous different than non-mucinous? And you can do the exact same analysis in lipidic versus non-lipidic. So let's focus more on that. Okay, any other questions?
No, thank you.
Okay. Anything else you looked into, Changwoo?
Mm. I tried to find any statistical significant results within the IMAs, and also I tried to compare between Tempest and Seer by comparing IMA and non-IMA patients.
Mm.
So I think Dr.Chae will present about that.
Okay. Let's see what that looks like.
Dr. Chae,
Mhm.
can I ask you a quick question about his data?
Uh-huh.
I was looking at this analysis yesterday, and we found that with N2 unilateral, if it's according to AJCC, the stage is different, depends on if it's T2 2 or T3 4.
Mhm.
So it's divided as stage 3A and B.
Mm.
But with mucinous, if you have N2, the T didn't seem to matter at all. So the survival was not significantly different, whether you had T1 or T4. So would that have any clinical meaning or significance?
Mm. That's for mucinous.
Mm-hmm.
And is that something mentioned in AJCC? Or is
We
this
haven't
something
looked
found in the seer data?
CR data.
Can you show me that data? So whether it's mucinous or non-mucinous, N1, 2, 3 all have distinct prognostic values.
Mhm.
But when it comes to T, it might not.
Mm. I think um, I think we could show that data later.
Okay, why don't you work on finding the data? I'll come back to you. We'll do the Rachel's data first.
Mhm.
Rachel, can you present?
Okay, let me show my screen. Um, from the a few days ago, like last week, I'm working with Dr. Chae, and then I originally I used the criteria for bronchial alveolar mucinous carcinoma and minimally invasive carcinoma, but yesterday I corrected, and then the criteria is same with the Tempest criteria. So title I just write down on it after discussion with Dr. Wongi, but maybe we have to change it. Yeah, so clinical manifestation and outcome of IMA and non-IMA real world data from SEER database. And as what I'm saying, study cohort eligibility is same with Tempest. And then so that the criteria includes like mixed. I was a little confused about it because Tempest included criteria for mixed mucinous and non-mucinous, the diagnosis code in the criteria. So but yeah, the criteria is the same with Tempest. And then this is demographic. From SEER data, I collect the cases about 400,000. And then mucinous was 4% and non-mucinous was 93%. So
incidence of mucinous is lower than non-mucinous. And about gender, yeah, like this. And then age, I divided to 4 groups, less than 60 and 60 to 69, 70 to 79, and more than 80. And race is white, black, other 3 groups. And laterality, I divide to unilateral and bilateral, and there are some lack of information, so non-NA shows that. And T stage, I divide to T1, 2, 3, 4, and NA, and stage also divide to 4 groups and NA. M stage include 3 groups, only 3, 0, 3, 1A, 3, 1B. And I also collect the data for treatment.
Oh, go
This
back,
is over.
go back. So
Sorry?
go back.
Okay.
So there is 53% and 0. I think that's really noticeable difference. I would also, there was no M1C. I think because this was the old AGC classification.
Oh, actually, I think there are some M1C data, but I didn't collect it because it's my bad because I was focused on M1 A and B. So yeah, if you want, I can collect it, include it.
Oh, you have to be comprehensive. You have to write
Oh,
everything.
okay, will do.
Yeah. But anyway, M0 is probably higher, 58% versus 49%. So you have to run ANOVA for at least that where you have the data available. And write down the p-value for each.
Oh, okay, I will.
Okay.
And then this slide shows overall survival. The incidence of the mucinous is lower than non-mucinous, but overall survival is better than non-mucinous. Yeah,
Oh, this is really interesting. I bet
yeah, yeah. I
I
was
bet this is the result of the higher instance of N0 and M0. So this
yeah,
is the direct opposite of what Soin showed us.
yeah. Very
That's
interesting.
why that's why we cannot lump all stages together.
Yeah.
Anyway, it's okay to show it all stages, but you have to run it stage by stage.
Okay. I also did write that. Like, I also divide to almost every stage, and I compared, yeah, between them. First one is I did compare between stage L localized and regional distance, and then this one is localized stage, and overall stage the same. I think same with overall survivor at the localized stage, lower incidence of mucinous carcinoma, but better survivor rate. Yeah, but yeah, this one is same, but at the distant stage, it shows different. Also lower incidence of mucinous carcinoma, but it shows worse survivor rate. So I think it could be worse prognosis at the distant stage. And next one, I compared.
Can you go back? Can you go back?
Yeah.
So when you say distant, what variables did you use in the SEER database?
Actually, the CR database already set the categories, localized and regional and distance. So I just click the button for mucinous and distance versus non-mucinous and distance.
But did you look at the definition? What does distant mean?
Oh, I didn't.
So distant is not a clinical, definition. Distant can mean anything. So does it mean stage 4? We do know stage 4 bilateral and 0 are
Yeah.
stage 4. Does it include that, but still confined to the lung? Would you call that distant? Or would you call liver, bone, brain, those as distant? So I don't know their definition of distant. So when you use variables, you have to know what they actually mean.
Yeah.
Anyway, assuming this is stage 4, now this is showing, I mean, although it looks like it's all overlapping, it's the p-value because there's so many people in the data set. There now seems to be a better. So here, when you show Kaplan-Meier curve like this, you need to show hazard ratio and the p-value. Okay.
This one, you mean?
So this might mean hazard ratio is 1.45. So
Mhm.
5% increased risk in non-mucinous. Not sure. Yeah, whatever it is, it's really small. And probably not clinically significant, but because of the large sample size, it is only statistically significant.
Oh, got it.
Okay, go ahead.
And next one, I compare the compared groups between N1 to 3 and 0 based on T stage. Overall, this shows no statistically significant difference between the T stage over more than 0.05. So p-value is too high. This one. So no statistically significant difference was noted between mucinous and non-mucinous based on T stage with N1 to 3 and 0.
Why did you not do N0?
Uh,
So, okay, go back.
go back. Did you this one?
So N0 mucinous did better. This is really interesting, right? Because this
Yeah.
mucinous did worse.
Mhm.
So let me tell you, mucinous N0 may be the type that spread through airway only, majority at least. And a lot of times these can be slow growing.
Mhm.
So I think this means something N0 that there's such a big difference. I think this is worth presenting. So did you do in all N0, what is the impact of T in mucinous versus non-mucinous? Did you look into that?
You mean and T zero stage with the T stage?
No, the impact of T
Mm-hmm.
in N0 population,
Oh.
looking at mucinous versus non-mucinous.
Okay, I will do it. I just compared the N0 missions versus non-missions. I didn't do about the T stage on T0. Yeah.
Okay, why don't you do that? Because you did it for N1, 2, 3, the impact of T.
Yeah.
So the conclusion is there is no impact of T. N trumps, N is the most important. Now the T might be important when N is 0.
Oh,
So you haven't done that. You can do that and show it to me.
okay, I will do.
Okay, go ahead.
And this one is at compare N1 missions versus non-missions, but there are no statistically significant difference. And two about N2 stage N2, the survival rate missions get worse than non-missions. Is N stage is same with N2. Yeah, next one I compare the groups between bilateral and 0M1A mucinous versus non-mucinous. It is different in overall survival because lower incidence of rate, but worse because the overall survival rate is mucinous was better than non-mucinous, but this one shows that mucinous is worse than non-mucinous.
So, so I think it's a small sample size now, but
Yeah.
I think it's still, 292 versus 43. I think this is still true.
Oh.
Now, again, M1A includes a lot of
Yeah.
high risk factors. So if you can tease out
Okay.
bilateral lung cancer from this cohort
Mhm.
and see if this curve still makes sense in that subgroup.
Very good.
So let's look into that.
Mm.
But I think this is telling us what Thoin showed us.
Mm.
These mucinous immune suppressive. These tumors are going to be treated with immunotherapy, chemotherapy. They're not going to be as responsive as non-mucinous. So they're going to do poorly. Versus N0, they do better because they're usually more indolent when it's N0, and you can just resect them surgically, SBRT. So their immune status doesn't matter. You just take it out. So I think understanding the two different spectrum, it's same mucinous, but biologically they're very different. It's almost like TGF beta.
Oh.
It's like a double-edged sword. Okay. Go ahead.
Mhm. And I also compare look at T stage of T stage on N0 M1A. This one is T1 mucinous versus non-mucinous is similar with overall survivor and incidence rate pattern.
Mm.
This one is like no statistically significant differences between them. This one is already shows worse prognosis survival rate again at the mucinous carcinoma. This one also same with his T3. Yeah, so only T2 and 0M1A shows no significant difference between them. And then I also look at the incidence rate between mucinous T4 and 0M1A and non-mucinous and T4 and 0M1A is similar, not similar, like mucinous T4 and 0M1A is has higher incidence rate. So because overall incidence of mucinous overall mucinous incidence rate lower than non-mucinous, right? But at this stage, mucinous shows higher incidence rate.
Hmm.
This one is unilateral T1 and T3 and 0. There are some significant differences between them. This one is no significant differences.
What is the difference?
Because p-value is over than 0.05 and then
No, go back. T1.
T1, yeah, it shows, but I think these n like case is too small for mucinous carcinoma, so I don't know is meaningful or not.
Okay. Okay.
Yeah. This one is T2
Okay.
and this one is T3. No significant differences between them.
Okay.
T4 also nothing. And this one, oh, here I found that like mucinous, there are no significant differences between unilateral N23 M0 versus bilateral N0 M1A, but as this one and like non-mucinous carcinoma shows I was a little confused about it. I mean, non-mucinous carcinoma shows no significant differences, but mucinous carcinoma, some stage they show significant differences. Yeah.
So stop right there. So can you separate M1A N0 mucinous to just bilateral parenchymal disease versus other? Can you do that?
Yeah, I will.
Here you have bilateral N0 M1A.
Mhm.
So that's different than just M1A because you specified it has to be bilateral, right?
Yeah.
But it could be pleural disease, pericardial effusion. It could be any of those, correct?
Yeah.
Okay. So I
Yeah,
think
okay.
we're not interested in those. We're only interested in parenchymal bilateral disease
Oh,
because the M1A really muddies the picture.
yeah, it
And
is.
that's not our focus of interest.
Okay. I think last of it is about the M1 N0 versus M1A, so maybe you're not interested, I think. Yeah, non-mucinous does not show any significant differences between them, so yeah, you can.
So yeah, tell me what the key message is.
First of all is about the incidence rate. Mucinous shows lower incidence rate than non-mucinous, but about the survival rate, mucinous shows higher than non-mucinous. That is the first one interesting key and a key message. And then mm, they-
Here, we call it TNM staging, okay? But there's a reason that every staging system came up with stage 1, 2, 3, 4.
yeah.
So what I don't see here is stage 1, 2, 3, 4. So TNM is there so that you can assign patient into stage 1, 2, 3, 4.
Mhm.
But it has never been used in any of your analysis, Chongwoo and Yujong. So definitely incorporate staging there. But then the bilateral parenchymal disease is a separate subtype you have to compare. Sometimes within that category. And again, the lesson is do not lump stage 1 to 4 altogether. It has no meaning.
Mhm.
And again, NNT staging is there to assign patient to stage 1, 2, 3, 4. So it's okay to do T and N based analysis, but these are all done as more of an exploratory analysis.
Mhm.
I think the message is here clearly that when it's local, mucinous is better. When it's distant, mucinous is worse.
Mhm.
We see that clear pattern. But then what I don't see is the parenchymal bilateral, not the whole M1A. So we want to know how the dream candidate patients will be able to can perform compared to other non-candidates.
Mhm.
So that's number one. Number two, yes, we are interested in N0 theoretically, but our dream protocol allows hilar lymph node, and that's N1. So how do mucinous N1 so we're not interested in unilateral disease. You know why? We can resect it. We can give
Yeah.
chemorad and cure it. We don't have to give them transplant. But when it becomes bilateral disease, we have no way to give them cure. So that's why we're interested in bilateral. But when there's a pleural effusion, malignant pleural disease, we can't cure them. So we don't offer transplant.
Mm.
So the analysis should really focus on who is dream candidate and stratify them by N0 and N1 because we do allow N1s
Mm.
as long as they are just hilar lymph nodes only. We do allow them. So are those patients gonna do okay or are they gonna do terrible because they're mucinous and they like to spread and come right back. So this is a dilemma that we have. Should we include N1 in our dream program or should we not? I think Dr. Barat and I discussed as long as we give chemotherapy or radiation, we should still include them, is the current sentiment. But now you know the focus, so why don't you do the analysis again
That's what we do.
and show those meaningful differences. But at the time being, for the world lung, I think by staging, and I'm saying staging not by the T or N alone, you can show that low stage mucinous is good, high stage mucinous is bad. You um and I wouldn't lump everything together, the stage wise. And then I would look at the bilateral lung disease N0 and in that specific situation, would mucinous do better or worse? And if they do particularly worse, and with advanced stage, they don't typically do well, they can be a particularly good candidate for double lung transplant. So sort of like the building that story, in an, in an abstract is fine. So I think continue to work with Chongwoo, and maybe you guys can write up one abstract together for the World Lung in San Diego. And yeah, try to write that up in next couple days. Yeah, and Dr. Liam will be able to help you in the lab. Any questions?
No, everything's good.
Okay, thanks.
Thank you.
We'll go to Dr. Wongi. Welcome.
Yeah, thank
And
you. So Monica is here.
oh,
Yeah,
Monica's
Dr.
here.
Monica's here.
Oh, Monica, are you from
Hello.
coming from
Hi, Dr. Chae.
Kathmandu?
Yes.
Wow.
I see so many new faces.
Congratulations again. I see
Thank you so
beautiful,
much.
beautiful pictures of you and your family.
Thank you so much, Dr. Chae. Thank you. Good to see you and everyone. Yeah,
Okay.
sorry for being a bit late.
Oh,
Yeah,
no,
and also
no
sorry for
problem.
not putting my video. I was out. I've still not. I just got home. uh,
Oh, did you
so,
travel?
no, I had gone to the hospital with my cause, but it just took a lot of time, more than I
Oh,
expected.
okay, okay. So
Yes,
yeah. Give us any updates that you have. I know you, yeah.
Uh,
What time is it
I
there?
it's 9 o'clock, 9
Oh,
p.m.
9 p.m. Okay, not bad. Okay.
Not bad. So I did receive some updates, like changes that had to be made from
Yeah.
EM. Uh, I've deleted the previous graphs because I didn't make them and I wasn't comfortable enough to add them. So for the tumor predict response, I have put in like a sensitivity, specificity, and whatever values that was sent to me by Dr. Yuri previously, and put in like a resist versus IR resist table. The next I have put on is a progression-free survival and overall survival, comparing resist and IR resist table, and demographics only for IR resist because in our model predicted IR resist better than resist. So if you can see, the AUC is just around 55% for resist, but is like 61% for IR resist. I wanted to ask you if you still want me to put the demographic details for resist and IR resist both, because I've just added IR resist because since it was significant, that's all I added up. But I can definitely
IR
put up.
is better, but I don't like the sequence. You have to do the demographic first, and then do the PFS OS analysis, and then do the prediction. So the sequence has to
Oh,
be
okay,
opposite of what you have there. And
sure.
every
I can
figure
change.
has to have a title.
Oh, I'll add up. I just did this morning. I
Okay,
didn't
okay.
have time. I still have a few editing before. This is not the
Yeah.
final one, but I wanted to, I wanted your
Yeah,
opinion on it.
the direction, yeah. So at least you
Yes.
have the right direction. I don't know if Dr. Yuri gave you the AUC curve graph. It would be
He
good to,
did, but it's just like a simple graph. I can show it to you, Dr. Che. Yes, there's so many things I wanted to
it's
discuss.
okay, it's okay. I want you to put the AUC curve, whatever it is.
Okay, sure. So I just have this. Is this fine if I just put this up?
Yeah.
Okay, sure.
It's always good to have slope of one line so that people can.
Yes, exactly. Yeah, that was the reason why I removed it in the first place, because I thought it was just a plain line and it didn't explain much.
Yeah.
But if you feel it
Yeah,
would be better
people,
to put it,
it's not perfect, but harmonization increased the AUC, so I would get 2 AUC lines. Yeah, along with the first table. But before you submit, work with Liam to, aesthetically, and then the numbers are too small, and just make sure
Yeah.
these are visibly well constructed.
Sure, sure.
Okay.
Dr. Chae. This is for the first one. The second one is for checkpoint inhibitor related pneumonitis. I've put in the curve over here and also trying to explain a few things. I know it's a little too small, but I will try to work on it.
What is the right side? What is it?
This
What
is just cumulative graphical. This is how Dr. Yuri gives us results. It's just these two. And based on this, we add up a little things about the predictive value, true positive rate, false negative rates, and everything.
But what's the XY for the right side graph? What is that?
For
Like,
this one,
yeah.
so so this one is like the true positive rate. This is the true negative, false positive, false negative.
Oh, okay. So you should be able to explain that in the figure title and what it is, and
I will add
yeah,
up.
you can't leave the numbers that small. So aesthetically, you have to make sure it looks like an actual publication paper.
Okay,
You
I will
can't
do that.
leave
This
it,
is
you
my
can't copy
very
paste it, anything like, yeah.
yeah.
You have
But
to
this is
make,
the first one I did, so I wasn't sure of so many things, but I'll work with Leah, Dr. Chae.
yeah.
And the extra one which I added was this table. Just some more demographic updates about how many patients had pneumonitis, how many had radiation-induced, immunotherapy-induced grades, and the median time range. So this was from the first draft that I sent. This is what I added this today.
So here, so can you show me the table again? The responder versus non-responder. And you have in responder, time to pneumonitis was longer in pneumonitis if you do resist, but if you do IR resist, they're similar. So that's very interesting. Yeah, and then the immunotherapy related pneumonitis responder 11 and 5. So these are patient numbers or percentage?
These are numbers.
So I would definitely put percentage.
Percentage. Okay. I can put them in a bracket, right? Like
Yeah.
numbers, comma, percentage. Okay.
Yeah, same
Sure.
thing. And then you have responder, non-responder. You need to put the total number of, like n equals how many for responder, non-responder.
Okay.
Because that's just the pneumonitis. We don't know how many are in the responder, right?
Mm,
So out
In-
of how
in-
many responders, what percentage got pneumonitis, right? Because we're interested in that.
oh,
Out
well,
of how many total non-responders, how many developed pneumonitis, and
pneumonitis.
what's that
Oh,
percentage? So try to think what a good medical journal paper looks like. You read
Mhm.
it, and if it's something, if it's information that you want is not there, make it so that it has all the relevant information. And I think, Liam or Dr. Wangi can help you if you have any those questions. It's more
Yes,
about how
I
to
would
make
be
a good table and good figure. Okay.
okay, Dr. Chae. Yes, I would definitely need some help.
And then look at the method. This is the same one as the response predictor, but it has nothing about the how you measure immune pneumonitis. This is about resist. I would change the workflow. Don't use the same figure over and over in all the three posters. I would change it so that this one is tailored to the pneumonitis algorithm.
Pneumonitis. Sure.
Okay, so it doesn't have to be like a fancy figure, but whatever you can, just like the pneumonitis modeling, and then use the algorithm and all that. Okay.
Okay. Taking notes.
Yeah. And this is recorded, so you can watch it and yeah.
Yes,
Okay.
that's also.
So here,
Is there anything you want me to add?
I think the content is pretty straightforward. Yeah, it's okay.
The now is the one which is a little problematic because I did not submit this paper. I was not involved in this, but having to make a poster, it's oh, I'm so sorry.
So was this submitted
So the
to
mixed response
was this ever submitted? Liam, do you know?
Yeah, so this one was submitted by Dr. Cheon and accepted for poster presentation at AACR. And at the time when Dr. Cheon was signing off on the radiomics, these abstracts to Monica, she kind of out of a goodwill, and in hopes to helping Monica, basically gave Monica this abstract that was already finished and submitted. So she was just in charge of basically presenting it at AACR since it was submitted. But because everything was created before Monica, like Monica is not as acquainted with the data as she is with the other stuff.
Okay. Okay, so tell me what you did, Monica.
So I just found the draft and I just put it up there. The extra stuff that I did was add in a table based on the results that we discussed, like that has been written. But apart from this, I don't know, Dr. I don't even have the other data that is like that I can use to add up for this abstract. Like I don't have the research, nothing about the research, no demographics, no patient population, nothing at all. So I just had like as first something as a first draft, which I kind of made up, and then this morning I added in a table which explains a little bit more about the results. But I'm quite struggling with what else I can do with this. I asked Seong, she did send me some tables, but they did not correlate with this. So I assumed they were, I don't know, maybe a step earlier or a step later one, but it did not really correlate with any of the numbers that was put in the abstract. So I couldn't use that either.
So, Seong, were you involved in this project, Seong?
No, this was also I just helped Dr. Jian submit this, the logistics, but I don't know about the data or what 127 patients that was used.
So Liam, was this just done by Dr. Jian alone when this project was ongoing?
I think it was her and Tegu, but they I did try to follow up a lot on this particular abstract. I used to ask Liam a lot because I never received any updates. Although
Mm.
I was put as a primary author, I never received any updates, nothing at all. But now suddenly having to make a poster it's become challenging for me, honestly.
Mm. Mm. This is why we need a good sign out. So every
Right.
project, every person who leaves the lab, we need to assign who's going to be the primary person to and if there's no primary, by default it goes to Liam. So so Liam's kind of in charge of knowing who's doing what, but anyway, I think yeah, Taegyu and Jiyeon worked on this, and I guess because this is a radiomics project and you took all the radiomics project, Monica, that's why I think it came to you. But the question we're asking is same thing. Can the radiomic features predict mixed response? And the answer is, what is the AUC?
The AUC is, I don't even know if it's properly mentioned or not.
It's 0.71 and
0.7?
0.62.
Yeah, so.
So I would put AUC curve for definition A and B. I'm sure Dr. Yuri had that given to Dr. Jian or Taegyu.
Mm,
So we need that. And there was a paper I think Taegyu was writing on mixed response. I'm not sure where that went. So we have a nice figure describing definition A versus B.
mm.
Dr. Jian has it, Dr. Taegyu has it. I don't know who else has it. But use that figure to describe what those definitions are visually.
Sure.
Hmm, I don't know. Liam, did you get any update on Taegyu? Does he have any ability to do research, or is he like all tied in the military?
He's pretty tied up. He said he wanted to do a little bit, but he hasn't been able to do much.
Okay.
The problem is they take a lot of time to respond. Sometimes they don't even respond.
Hmm.
So yeah, it's pretty hard to reach out to
Yeah.
them for anything.
Well, it's same thing where you're going through, yeah.
Yeah.
Unless
Yeah,
this
they
is your
couldn't.
primary work, yeah, the same thing when you start your residency, you're not gonna be able to do much.
Yeah.
So,
I mean, I understand, but it's just so difficult sometimes. It feels like just give me half an hour and I'll be on my way. But then even that half an hour is difficult.
yeah. So I think if we add those two figures, and make, so this table, same thing, you need units, table, title, all of that.
And
Then
then
it's just,
add the definition
yeah,
of mixed A and mixed B, right?
yeah. And
Okay,
I think
sure.
you should be okay.
I will.
So, I mean, Dr. Jian did all the work. You're just making it for her.
Yes, technically, yes.
So
Uh,
I think Dr. Chian should be the first author. Whoever did the most of the work, I think making table, poster is making table, like literally. But going through all the data, and doing the analysis, I don't know if Taegu did the most work. I actually don't know. Liam, as a manager, why don't you do some more investigation and try to
Right.
assign a fair,
because even this is like it doesn't feel very much fair. Honestly, it's
yeah,
Yeah.
I don't want
So
it's
was
taking a lot of
it
hassle to
was
just put my name on it. Yeah.
it was genuinely like out of the goodness of Dr. Chian's heart that she made Monica the first author for this one.
okay.
The intention was so they submitted this like as soon as the portal opened up so Monica could actually submit an
Yes,
abstract to
but I was not the
AACR
first
for her
author for
cycle.
it. I was not the first. I wasn't made the first author, but later on, when she got really busy, she said she doesn't want to be involved in it. That's when I was made the first author by her. And this was way after every submission. And although I tried to catch up a lot regarding this particular abstract, because I wasn't receiving any updates or anything, even though I was like changed to primary author. And I that's just how it happened. Anyways, but we'll have to do it. So I will try to put up, like you said, Dr. Chae, and let's see. Let's see.
Yeah, so why don't you do, so Liam, are you gonna print out the poster and hang it? Because
Yes.
Monica's not going.
Yes.
Yeah,
I'll be in charge of the
okay,
and ordering the poster.
yeah. So Monica, I think for the poster, we will give you credit um by assigning you as a first author for the poster. I think that's that's a big credit to you and for your academic career. For the actual manuscript writing, we will definitely, see who spent more time with the project and assign authorship there. Not sure if you ever will have bandwidth to write this paper or have interest. You're welcome to let Liam and me know what you want to do, and we'll be happy to reflect that. But as far as the poster is concerned, I think your main role was the project manager for all radiomics project. So we appreciate that the fact that you are involved in the poster generation. So we'll give you that due credit for the poster only, but for the manuscript, we'll do something different. But work on this, and I think it's great that you are still trying to finish everything from Nepal. So I appreciate all your efforts, and I really hope that a lot of good radiomics paper, you would finish writing it up and submit it before you start your residency. I know it takes a lot of time, but you have Liam and everyone who can help you. Yeah, but if you start your residency, it's going to be really, really difficult to, really write things up. So I, advise you to, finish up your manuscript as soon as you can. But for the poster, I gave you clear directions and we'll print it.
Sure. Thank you, Dr. Chae.
Any questions?
No, I don't have any from my side for now. I will redo this whole thing, and I guess by tomorrow earliest hour, I will send everything to Liam to see if there's something more feedback from you.
Okay. And when Seong joins, because I know Monica, you're gonna have to start your residency, not but Seong will come in all the radiomics projects, including the mixed response. Seong will be the radiomics project lead for every project responsible
That's
for
fair.
writing.
Yeah.
Yeah.
For mixed response, I'm like, I don't yeah, I just don't want to take the authorship at all because it doesn't feel fair enough. I didn't work for it. And it's honestly really difficult from my part to trying to understand all this over a short span of time. But I understand it. I'm really comfortable sharing everything with Seong because she's worked on it so much. I think yeah, anybody, I think Seong would be a perfect one to fit
Yeah.
as a lead.
So whatever you know, I know you signed out many things to her. Just make sure she knows everything you've done. Same
Sure.
thing, you get, if Monica doesn't have it, get it directly from Jian and Taegyu, all the data that was generated on previous projects. So, okay, let's go to Dr. Wangi.
Thank you.
We have only 15 minutes.
So I only have I finished 2 manuscripts for last 2 weeks. So I think this one is metastacectomy is much shorter than the pan organ analysis one. So these are also released for this project. And I think you saw the abstract before, and so maybe we can go straight to some introductions. Yeah.
Oh, can you show me the title again? One more
Title again, yeah.
So the role of pulmonary metastatectomy for non-primary lung cancer. Umbrella review of meta-analysis. Okay, non-primary lung cancer.
Yes, it was difficult to find what would be the better one, but I think it delivers the main message. So
Yeah. So you reviewed only the meta-analysis papers?
yeah, and after that we selected each studies and we made analysis. So we called umbrella review.
Okay. For meta-analysis, let's change the spelling to SES then. Review of meta-analysis. SES. SIS.
Yeah.
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 Okay. Introduction
Introduction here.
Control surgery alone in case. Okay, go down. First perform. Controls. Okay, looks pretty good. Method. Okay. Okay, good. Fraction. Okay. Okay. Statistical analysis. Okay. 16. Okay. Okay, go down. Okay, let's look at the figures and tables and come back.
Okay.
I think it's all.
So So this is a table. So this is the result from the re-meta-analysis of all included studies. So there are 7 types of cancers. And yeah, these are demographics and tumor characteristics. And this is I think, the main outcome of this paper. So here you can see the overall survival rates and the recurrence rate. And just a second. And this figure is just summary for yeah, this is summary for all cancer, like breast cancer, germ cell melanoma, other cortical. And this is the one that you saw in the abstract.
Yeah.
Summary of 5-year overall survival.
Mm. Okay. That's pretty good. Yeah.
So so this is a description about these results.
Yeah. Hmm. So melanoma is worse, but germ cells best. Okay.
And the discussion.
Hmm. Hmm. Okay, seeds, soil. Hmm. Hmm. Yeah, yeah. Why lung is so special, or yeah.
Yeah, so there was some paper about learning microenvironment. So we added that information here.
Hmm. Okay, looks good. Germ cell tumors. Okay. Hmm. Okay, go down. Okay.
This is about some surgical perspective.
Hmm. Okay.
The following table is about the new research needed.
Hmm. Okay, so ctDNA in PM has not been done,
Then I think this is one study, prospective study, only one. So there were not many. So
but this is any metastatectomy, not pulmonary.
yeah, no, this is pulmonary metastatectomy for yeah. Only colorectal cancer, not pulmonary, I think.
Probably liver and more.
Yeah.
Okay. So just say there, I don't think the pulmonary metastatectomy focused the study has been done, right?
Yeah, I think so.
So yeah, looks good. I like it. How about mentioning the dream trial, that the idea
Mm,
of you know, the primary taken care of and dream study core 2 is available as
So
a clinical trial.
I indirectly mentioned about lung transplant here.
Uh,
So what do you think? Do you need to specifically mention about
yeah,
the
I think you,
okay.
I mean, that's a nice bridging, and then you can say,
So we cite the Dr. Jian's paper here
hmm,
and or or just we can say that
yeah,
in
you
our
can say,
center. Yeah.
uh, you can mention the trial,
Mm-hmm.
dream trial, and the clinicaltrial.gov number,
Yeah.
like
Okay.
that. And then you can say cohort B addresses this specific cohort where, you know, it's metastatectomy, but to restore their lung function, transplant is provide, you know, something like, you know, it's a
Okay.
same concept as pulmonary metastatectomy, but in order to, you know, restore their lung function, we're offering transplant.
Mm-hmm.
So I think the concept is same for PM, but and then yeah, it's offered through a clinical trial program.
Okay.
Yeah, I think that's fine.
Okay. So
Yeah,
I will add that and
yeah.
share with Dr. Bharat, and I will ask him to suggest which journal will be nice. I think we sent many paper journal, they said no, but I think surgical journals maybe there are I think about 2 to 3 candidate journals. So I will give them the list and I will have his opinions about that.
Sounds good.
Okay. So, and panel analysis is very extensive paper. So we finalized, but I will share with all the co-authors. Is it
Mhm.
okay?
Yeah,
And yeah,
but that's done, right? The
yeah,
panel.
yeah, yeah.
Yeah.
So we have here.
But that got accepted to ASCO, right?
Yeah,
Yeah,
poster. Yeah,
yeah, I think that's great. ASCO doesn't usually take those. Uh,
transplant something, right?
yeah. But it's amazing. Okay,
Okay.
that's it.
Yeah, I will share the manuscripts through email.
Okay. So let's wrap up, and I will do. So Liam and Sally, you can just come to my office and discuss the projects with me. Yeah, but we're gonna do a testimony meeting in my office. So whoever you guys are here, come to my office. We'll start in 5 minutes. Though for those of you who are not physically in the lab, we're gonna use the
Is that the link in the group
test
chat, Dr. Chae?
testimony. Yeah. So put the link in the GVM chat room so that Taeyong or Connie or Sue may be able to join. I'm sure it would be a great time. I invited Dr. Saw, who's our radiation oncologist, so he'll share his a life story with us. So I'll see you guys there in 5 minutes. But yeah, I'll see you in my room too.